ideal opportunity to announce our first speaker. This is Dr. Albert van Zijl, who is from South Africa, and he finished his specialty training in anesthesiology at the University of Stellenbosch in South Africa, and is our first ever EACTAIC fellow. And we were very lucky to have him because he's really an ideal fellow. So we are really happy to have him with us. And he will now talk about the place of the pulmonary artery catheter in modern cardiac anesthesia. Albert, it's up to you.
Thank you very much for the introduction. My name is Albert van Zijl. I'm the current EACTA fellow at University Hospitals Leuven. I can definitely attest to what Dieter said. The strength of Leuven and the fellowship here is the caseload. It's absolutely incredible. I'm halfway through and I'm excited to see what happens in the next 6 months. So tonight I'm going to be discussing the topic and the contentious issue about what is the place of the pulmonary artery catheter in modern cardiac anesthesia. I have no declarations of note. So the history of the pulmonary artery catheter is actually quite a distinguished one. From when William Harvey described the circulation for the first time in 1628, advances in right heart catheterization went on to win the Nobel Prize in 1956, and further modifications by Jeremy Swan and William Gons allowed its use in the 1970s at the bedside and in clinical practice. However, despite its widespread use and this very distinguished history, in the 1990s and the early 2000s, in the last 20 years, basically, it has been called out to be both useless and useful, both harmful and not harmful, and it was even declared dead by some. So how do we interpret these conflicting statements regarding the pulmonary artery catheter over the last 20 years, and how do we then make sense of its place in modern cardiac anesthesia? Well, to do that, we do need to have a look at existing literature. And although a thorough literature review of pulmonary artery catheter use is definitely out of the scope of this talk, let's look at a brief summary. So initially in the 1990s and 2000s, there were no RCTs available, and the role of the pulmonary artery catheter became hotly debated as early observational studies showed increased mortality associated with its use. In the 2000s, subsequent randomized control trials and then obviously meta-analysis that followed on these RCTs failed to show any clear benefit or even increased morbidity and mortality associated with its use in a variety of clinical settings and populations. The same for cardiac surgery. Literature was very sparse, and it also showed no benefit or harm. Intensive care literature in the 2000s suffered much of the same. The RCTs and subsequent Cochrane reviews and meta-analysis failed to show any clear benefit. It's no surprise that the outcome of these studies were a decrease in the use of the pulmonary artery catheter in a variety of settings. But the literature about the Swan-Ganz catheter, or the PAC, suffers from a lot of flaws. A few is mentioned here. Most of the studies were retrospective. Some of the RCTs were powered to detect 10% difference in mortality, and this is for a pulmonary artery catheter monitor. And it should be noted that most of the large RCTs examined the routine use of pulmonary artery catheter, pulmonary artery catheter use, and it enrolled a sequential cohort of patients, the majority of whom had a relatively moderate to low risk of death or complications. And not all of them, very importantly, employed a specific therapeutic protocol coupled to pulmonary artery catheter use. And this is very, very important to note. And I stress this point because the pulmonary artery catheter is essentially a monitor. And it's impossible that a monitor without any intervention can lead to any sort of benefit in any patients. Therapeutics change outcomes. Monitors do not do that. And it's indeed so when you look a bit deeper in some of these studies, and when examining non-randomized studies, which included very high-risk patients marked either by old age, severe comorbidity, increased disease acuity, they were able to demonstrate some clinical benefit from the pulmonary artery catheter use. When looking at literature specific to cardiac surgery, many of the same limitations of the general literature pops up here. Once again, very, very sparse and conflicting. And we can see that existing studies in cardiac surgery is mostly observational studies. It excluded mostly severely ill patients. There was an overrepresentation of coronary bypass surgery, and valve surgery was not included. And there were no standardized protocols to compare with. What we also see here is there was no robust prospective RCT specific in the cardiac surgery setting done, showing any benefit or harm.